Walk into any active medical practice and you immediately feel the friction of patient care. Phones ring, schedules shift, and exam rooms turn over. But the most expensive failures usually happen in the quietest part of the office. Right now, Ohio healthcare providers are bleeding revenue. The root cause is a highly unstable front office framework struggling to manage modern billing requirements. The primary bottleneck is the workforce. According to 2023 MGMA data, billing staff turnover 0.3%. When a specialist leaves, the team absorbs the load. Claims delay, errors rise, and stress burns out remaining staff, creating a continuous loop of attrition. Medical billing requires specialized knowledge of specific electronic medical record systems and payer rules. You cannot maintain clean claim throughput when institutional knowledge constantly walks out the door. Treating revenue cycle management as an ad hoc internal administrative duty has become a source of systemic operational failure. We can see exactly how much this failure costs by looking at the math behind a single departure. The financial impact extends far beyond the gap in a payroll ledger. Every resignation triggers a cascade of recruiting time, onboarding hours, training windows, and a severe drop in operational productivity. MGMA benchmarking shows that replacing just one frontline healthcare support staff member costs between $25,000 and $30,000. If a mid-sized practice replaces 2 or 3 billing specialists in a single year, that translates to $75,000 to $90,000 in unbudgeted losses. This aligns with 2025 polling, where 90% of medical groups reported operating costs tracking significantly higher than the previous year. Operating on tight margins means you cannot continually pay a 5-figure training tax just to keep the revenue cycle functioning. While internal staffing creates a severe vulnerability for the practice, immense external pressure from payers is actively exploiting it. Ohio practices navigate a dense web of payer rules, specific state Medicaid structures, and multi-state compliance layers. Payers capitalize on understaffed practices to increase rejections. According to Kodiak Solutions, initial claim denial rates climbed steadily over 4 years, reaching 11.81% in 2024. Every denied claim carries a financial penalty. Data shows it costs $25 to $117 in staff time to rework a single denial. This creates a mathematical asymmetry. Payers deploy automated systems to issue denials far faster than an understaffed, rotating in-house team can correct them. Without proper operational reporting, practice managers know claims are leaving the office, but they lack clear visibility into actual denial rates or expanding days in accounts receivable. Relying on generalist staff to fight automated payer denials without catching errors on the front end guarantees an unwinnable war of attrition on the back end. The in-house staff that remains is often diverted away from revenue cycle duties to handle escalating administrative demands, primarily prior authorization. The AMA reveals that practices complete roughly 39 prior authorizations per physician each week, consuming 13 hours of staff time. In a multi-provider practice, that multiplies quickly. A small office easily loses 39 hours a week, essentially a full-time employee's capacity, solely to prior authorization. This administrative drain correlates directly with workforce exhaustion, with 94% of physicians explicitly linking prior authorization volume to clinical burnout. Every hour spent securing pre-approvals is stolen from claim scrubbing, from accurate documentation, and denial follow-up. Back-end revenue leaks are almost always the measurable result of front-end administrative time theft. Medical Group Management Association data outlines specific operational principles that reverse these negative metrics. The first principle centers on focus. Dedicated specialists operating exclusively within a single electronic medical record system consistently outperform generalists jumping between multiple platforms. The second principle is preemptive correction. Executing strict pre-submission audits and eligibility verifications at the front end is mathematically cheaper than funding a rework loop after a denial. The third principle requires continuous visibility. Reviewing key performance indicators weekly catches anomalies immediately, replacing the delayed reactions caused by monthly guesswork. Finally, the revenue cycle requires absolute role isolation. When the employee responsible for submitting complex claims is simultaneously answering phones and checking in patients, quality drops. Achieving true revenue optimization requires strict operational isolation of the billing function from general administrative noise in the office. Implementing these operational best practices requires a permanent structural solution that completely removes the unpredictable variable of local staffing. High-performing Ohio practices bypass the hiring loop entirely by adopting an outsourced, dedicated seat billing model. This dedicated seat model embeds AAPC and AHIMA-credentialed specialists directly into the practice's daily operations, functioning as a permanent, specialized extension of the internal team. These specialists operate directly inside the practice's native EMR system, connecting through secure, encrypted VPNs to maintain absolute data continuity and exact workflow alignment. The economics shift from volatile to fixed. Hiring an in-house medical billing specialist requires $55,000 to $75,000 annually. Staffingly provides a dedicated seat for $399 a week, a predictable cost of roughly $20,000, without massive turnover overhead. The dedicated seat model structurally insulates the practice from local workforce shocks while establishing fixed, predictable economics. Staffingly enhances stability by deploying AI-augmented workflow tools that route tasks based on complexity and priority. Automated background audits run continuously on every action, flagging anomalies before they establish pattern errors, driving the overall error rate below 1%. Operational integration takes exactly 14 days, executing a strict month-to-month structure with 0 long-term contracts. For Ohio healthcare practice owners, the absolute path to revenue optimization is immediate, precise, and completely ready to deploy today. If you're dealing with rising billing costs, claim denials, and staff turnover, go to staffingly.com/demo or call 800-489-5877 to stabilize your revenue today.